All right, welcome everyone. My name is Haley Bell. I'm from the Heartland Telehealth Resource Center. Thank you so much for joining us for today's HTRC education series topic focused on telehealth billing, coding, and policy. Before we get started, there are just a few notes for you. This session is being recorded and we will share it with you afterwards in that follow-up email. Your microphones have been muted, so please use the chat to ask questions as we tend to have a large group during our sessions. And then if you would like a certificate for attending the session, please contact us at htrc@kumc.edu. Please be sure to include your full name as you would like it to appear on the certificate. And then to get started, I'm going to introduce our speaker today, Richelle Marting. Richelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, reimbursement, as well as HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Richelle with us today to take a deeper dive. So I will go ahead and turn it over to Richelle. Thank you so much.
Thank you, Haley, and thanks everyone for joining. This is sort of a part two to the series that we started in July when Medicare released their proposed policies for calendar year 2025. And now we have the final policies to review with an emphasis on telehealth, enhanced care management, quite a few new behavioral health services that will be covered by Medicare and paid and reimbursed in 2025, as well as some policies that are specific to RHCs and FQHCs. Got a lot of information to cover today. So it's about 3,088 pages in the final rule, and we're going to go through those 3,088 pages, at least as many of them as we can. So one thing I want to make sure I emphasize, prior to the next year's proposed rule with Medicare, there's a really important deadline that everyone keep in mind, February 10th, 2025. The link is on this slide that we'll send out after the session. But if your practice, if your organization provides telehealth services currently, you'll want to go to this website and submit comments, questions, proposals specifically related to telehealth that you want CMS to consider in the 2026 Medicare policy. And I'll explain why doing that is so important this year in just a few minutes. But I want everybody to be aware that that deadline is coming up, will be coming up soon. So without further ado, I'm going to jump into some of the final policies that came out of the Medicare 2025 final physician fee schedule. Telehealth, of course, has been a popular topic that has dominated a lot of those 3,088 pages for the last several years, especially since the COVID-19 public health emergency. One of the biggest takeaways I had from the final rule this year is none of the codes and services that are currently on Medicare's list of provisionally covered telehealth services, so those that were made available during the public health emergency, that have remained on the list with annual extensions for the last couple of years, none of those were proposed to be converted to permanent telehealth codes. One of the reasons I think that is so important is that Medicare said they're holding that evaluation on a code by code basis at this time because they want to do a comprehensive review of everything on this provisionally covered telehealth list and formulate final policy in a comprehensive manner. That's one of the reasons that this upcoming February 10th, 2025 deadline is so important. If you, your professionals, or your organization provide any services via telehealth that were not available as telehealth services prior to the COVID-19 emergency and are only covered right now provisionally through rulemaking over the last several years, you will want to revisit that list of those services that have been provisionally covered. Submit your comments, submit your requests, your feedback to CMS on why those services may be appropriate to continue on a permanent basis, that they're safe, that they're effective, that they improve access, so that Medicare can use your comments and use your feedback for upcoming rulemaking processes. What Medicare did do, though, is look at a few codes that they would consider actually removing from the telehealth list, which isn't very common. CMS was looking at removing the radiation treatment management code from the list of eligible telehealth services, but did not finalize that policy. Those of you, if you're in cancer centers or have radiation oncology providers, 77427 will remain on the list of covered telehealth services for next year. Home INR monitoring was proposed to add to the list, not on a permanent basis, but provisionally, and that was not finalized. So in 2025, code G0248 will not be a part of the covered telehealth services list, but caregiver training will be added, and there's several new codes that will be added to that list. Those that were made permanent as kind of brand new codes for 2025 were done so not because they were previously provisionally covered and now will permanently be covered, but instead because these are brand new codes in 2025. And as part of that new code creation process, CMS looked at these and said that they meet the criteria to be covered as eligible telehealth services. Another thing that CMS did in the rule for 2025 was take a look at some of the telehealth policy that has been made available through the public health emergency and then extended afterwards. Some of those proposals that CMS was considering, do we remove these flexibilities? Do we make these permanent? Things like frequency limits on how often professionals can see patients in a skilled nursing facility or in the hospital setting via telehealth rather than a face-to-face in-person visit. CMS decided to continue those flexibilities, but these are orange check marks instead of green because CMS is extending it for 1 year rather than making these flexibilities permanent under the Medicare program. And that's been a trend that we've seen for a few years now. So the pre-public health emergency limits of seeing patients in the hospital setting via telehealth of once every 3 days, or skilled nursing facility telehealth services once every, used to be 30 days, it was reduced to 14 days. Those are waived for 1 more year, meaning in the hospital setting and skilled nursing facility settings, critical care consults, the frequency limit of seeing patients in those settings via the telehealth format in particular is waived, and providers can continue to use that format as often as is medically reasonable and appropriate. The critical care consult code, that's G0508 if you're using that for patients in the hospital setting. That has also had a frequency limit that is waived for 2025. Another thing that CMS zoomed in on are some of their policies surrounding the format of telecommunications, where CMS proposed to permanently describe telecommunication technology as two-way, live, audio only, or permit audio only, I should say, as a permanent telehealth format. And that was not finalized as a permanent change. So interactive telecommunication technology under the Medicare program is two-way, real-time, audio-only services if the patient is in their home. But if the patient is in an originating site like a clinic, like a hospital, those must be delivered by audio-visual communication technology. Now, another interesting part of this change, this final policy, allowing audio only to a patient in their home in 2025 and beyond. It requires that Congress act before the end of this calendar year to either extend or permanently make available the patient's home as an eligible originating site under the Social Security Act. Unless that happens, then this provision allowing audio-only communication for patients at home will never really come into effect. Medicare doesn't have the ability through rulemaking to allow the patient's home to be an eligible originating site on a permanent basis. That requirement and the list of eligible originating sites falls under the Social Security Act. So it takes an act of Congress to make that change. The latest perception is that it is a bipartisan issue to support the expansion of telehealth services, and there is an expectation that that rulemaking, or I shouldn't say rulemaking, that congressional action will happen, but it's November 20th. We're running out of time with about 6 weeks left in the year, that we hope to see that pass before the end of the year. If, and let me go back to the policy that CMS implemented, and assuming that CMS does pass, or excuse me, Congress does pass the act that allows the patient's home to be an eligible originating site in 2025 and beyond, CMS also allowing audio only to be the format in which telehealth is delivered when patients are at home is limited to circumstances when the distant site provider or practitioner is technically capable of using audio and video equipment. But the patient is either not capable of using video, bandwidth technology, they don't have a camera, etc., or they do not consent to using video as part of the telecommunication technology. Only if A and B provider has the capability for video, patient cannot or does not consent to use video, can the telehealth service proceed as an audio only service. And again, this is Medicare only for 2025. So to flip gears a little bit, that's talking about the patient's home, the eligible originating sites, and talk about the distant site providers. So through calendar year 2025, this is an orange check mark because it wasn't made permanent, but it is extended for at least one more year. The distant site provider can continue to use their regularly enrolled practice location instead of enrolling their home or other temporary site as a practice location with Medicare. So what that means is during the public health emergency, we had a lot of providers begin to deliver services via telehealth from home. That might have been during a period when they were quarantined to reduce the exposure and infection, or for other reasons. And the question arose, does the provider need to enroll their home location as a practice location under the Medicare program? And the answer at that time was no. And during the public health emergency, the provider could use their regular clinic location as the practice location for their enrollment. However, there was some question that arose after the public health emergency ended, whether the providers could continue to use their regular practice location rather than their home. And CMS is extending that for another year, that providers do not have to add their home as a practice location. Direct supervision.
Oh, Richelle, it looks like you muted.
I did. Sorry about that. Direct supervision and virtual presence when it comes to telehealth policy is referring to when a provider is rendering a telehealth service, and in order to bill incident to, in order to bill under the physician's name and number, or a nurse practitioner for that matter, if services are being provided by other clinical staff in the clinic setting, typically requires a direct level of supervision, which by default under the Medicare program means that the supervising provider is physically located in the practice suite and immediately available to intervene during the service. Well, in the context of telehealth, that doesn't make a lot of sense to necessarily require physical presence in an office suite in the course of a telehealth service. So for billing policy, Medicare has allowed that supervising provider to meet the criteria of direct supervision, to bill for services as incident to, by being virtually present, being able to immediately intervene during the telehealth session. It does not require that supervising provider actually intervene during the telehealth session. They just have to be available. CMS proposed to make this a permanent policy, didn't make it permanent, but this is an orange check mark. They are extending that flexibility at least for another year. There are some services, some individual services that CMS is permanently making virtual presence a method that can satisfy direct supervision for incident to billing. They didn't do it more broadly, but they did finalize on a permanent basis a more limited policy. So what CMS was looking at are codes and services that, by their very description as CPT codes, inherently do not involve that supervising provider's personal attendance and personal services. For example, 99211, an established patient level 1 office visit, is frequently used for, sometimes it's called a nurse visit, for blood pressure checks, for INR clinics, those types of things, where it is a visit between a patient and a nurse who is not necessarily the billing physician or billing nurse practitioner. Because that service, by its own definition or description in the CPT book, doesn't require a qualified healthcare professional, a billing provider, to be directly involved, CMS said it makes sense to allow that physician or that nurse practitioner that's providing the direct supervision to do so through virtual presence. They're able to intervene during these services virtually. And that is true whether the service itself is being delivered in person with the clinical staff and the patient, or being delivered as a telehealth service between the clinical staff and the patient. The other scenario that CMS finalized on a permanent basis, where the supervising professional, the billing professional, can meet the direct supervision requirement for incident to services, incident to billing, are services where the RVS data file has a supervising provider indicator of 5. It's a really complex way of doing this. So to make that easy, I've just listed those codes on the next couple of slides. There's some dental codes. There are some suture removal, things that inherently, vaccine administration, are typically done by clinical staff and not a physician or a nurse practitioner necessarily. So on a permanent basis, the supervising physician or nurse practitioner can meet incident to billing requirements by being able to virtually intervene during those services. And I won't go through all the codes, but I wanted to make sure you'll have these on the slides that we send out afterwards. So another telehealth policy that was created during the public health emergency and has been continued year after year on an annual basis since the public health emergency ended involves teaching physicians in settings where we have teaching physicians and residents who are providing services to patients, and where teaching physicians and or residents may be doing some of their services through telehealth. On a permanent basis, CMS says the teaching physician, the concept that the teaching physician has to be available during a key portion of that service that the resident is primarily involved in order for the teaching physician to bill for the service. That can be accomplished through virtual presence with a little bit of a twist. Unlike incident to billing, where the supervising provider can meet the direct supervision requirement by just being available immediately to intervene. In order for a teaching physician to use virtual presence to attend a key or a critical portion of the resident service, the teaching physician actually has to be a part of that service. Or a portion, the key portion of that service, but can do so virtually through telehealth. So envision a scenario where the resident is face-to-face in person with the patient. Teaching physician can join a key or critical portion of that service virtually using telehealth technology and still bill for the service as the teaching physician. So I want to shift gears a little bit. This has been talking about telehealth policy specifically under the Medicare program, at least the portions of policy that CMS is able to effectuate or to extend through rulemaking rather than things that require an act of Congress. There still are certain policies that we hope and expect Congress will act on to make permanent changes or at least another extension under the Social Security Act. And they have been doing that year after year since the public health emergency ended to allow the patient's home to be an eligible originating site, to eliminate the geographic restrictions on originating sites like rural geographic areas or healthcare provider shortage areas, and also to allow rural health clinics and federally qualified health centers to continue to act as distant site providers and billers of telehealth services. Those three things CMS cannot effectuate through rulemaking. They can formulate their policies under the hope and the assumption that Congress is going to take that action. And that's what they've done in this final rule. But we have to wait for Congress to pass legislation to make those three things happen and continue effective January 1 of 2025 under the Medicare program. So now I'm shifting gears a little bit from true telehealth, at least in the way Medicare defines their telehealth benefit, to other services that may not, at least under the Medicare program, be called telehealth services, but from kind of a layperson perspective, we may think of these as telehealth in the sense that they're not necessarily happening face to face in person with a patient. These care management services are often happening behind the scenes in between face to face or in person visits with the patient, whether those are via telehealth or otherwise. And CMS continues to adopt policy to add various care management services over the last nearly decade. We started with care management services like transitional care management, which pay for the time and the effort and the work to help a patient transition from an inpatient or a facility setting back into an outpatient or community setting. Things like medication reconciliation, following up with the patient by phone, making sure they understand their discharge instructions, and then seeing the patient within 1 to 2 weeks of discharge. Medicare started adding new services like chronic care management, principal primary care management, behavioral health integration. If you are familiar with those, or you want to go back and visit some of our prior sessions that are on HTRC websites, you can learn more about those. But Medicare is continuing down this path to think of different types of care models and add benefits and add codes and add coverage and payment for things that providers are doing outside of their in-person face-to-face services. One of those that were added as an additional benefit for 2025 are enhanced care management services. So CMS is looking at a model of primary care management that is out in the industry that has good outcomes and good efficacy currently, and has begun to pay for those services or will begin to pay for those services in 2025. So this advanced primary care management service is based on the advanced primary care model of care delivery. It's designated as a care management service under Medicare benefits. And what that means is every code, every service that CMS designates as care management can be performed under general supervision instead of direct supervision, or general supervision instead of personal supervision. That means is the billing provider doesn't need to be the one personally and individually rendering the service, nor does the billing provider need to be in the office suite immediately available or leveraging virtual presence to be available to intervene virtually. Instead, general supervision just says the billing provider is the one overall responsible for the services that are being provided. And the other thing that allows professionals and groups to do via general supervision is sort of leverage vendors potentially, or contractors, or sharing clinical staff with other groups to kind of gain some economies of scale and spread out some practice expense for individuals to help carry out the clinical staff portions of these services. And CMS describes advanced care management or enhanced primary care management as recognizing and providing payment for situations where the provider is the continuing focal point for all needed healthcare services or responsible for all of the primary care services. Put that language in quotes because if you joined our sessions last year, there was a code that was created in 2024 by CMS, G2211, that is an add-on code Medicare expects would be added to nearly all primary care office visit or E&M services. Primary care, I'm using that term very broadly, or specialists services when that specialist is absorbing the responsibility over a longitudinal period of time to manage specific conditions for the patient. Infectious disease providers, for example, oncology providers may see that patient over a long period of time, as opposed to a short-term consultation. So that same concept of being the focal point for all healthcare services, responsible for all primary care, it's very similar to what we saw for G2211, but not quite exactly the same for enhanced primary care services. Only one practitioner can be the enhanced primary care provider biller per patient per month. And that makes sense. We're talking about the professional who has the primary, the key responsibility for everything that's going on with that patient, compiling all of the specialist information. So generally, we would only expect that to be one practitioner per patient per month. And that's not limited to group practices. That is, period. One practitioner can bill and be paid by the Medicare program per patient per month for these enhanced primary care management services. The list of professionals who can bill: physicians, non-physician practitioners, nurse practitioners, physician assistants, certified nurse midwives, and clinical nurse specialists. Medicare expects that the vast majority will be billed by primary care specialties, but primary care doesn't necessarily mean you have to be enrolled as a family medicine specialty with the Medicare program. That could be specialties like family medicine, geriatric medicine, internal medicine, but those disciplines that tend to serve in a primary care capacity or role for Medicare recipients. So I'm going to go through the codes that were established, and these, what I've got on the next couple of slides, are just the finalized code descriptors, so you can see what the codes are and then learn more about them if your organization is interested in adopting this model or already adopts this model and now wants to bill and be paid for some of these non-face-to-face services to Medicare members. So we have a series of, let's see, I think 4 different codes here. The first one, advanced primary care management, but I have emphasized provided by clinical staff. The payment for these codes are not valued under the assumption that the physician, the nurse practitioner, the PA is actually personally performing these services. And that makes sense because these are care management services that are generally done under general supervision, that are not personally performed by the physician, the nurse practitioner, the physician assistant. They're directed by, they're overseen by a qualified healthcare professional, the doctor, the nurse practitioner, the physician assistant, who has the overall responsibility for that patient's primary care management services. These are reported per calendar month, not 30-day period, but per calendar month. And I have with the following elements. I'm going to go through what those elements are shortly. There's a code for advanced primary care management for a patient who has 2 or more chronic conditions. Chronic conditions meaning a condition that's expected to last at least 12 months or until the death of the patient, and that place the patient at significant risk of death, acute exacerbation, or decompensation. So these are things like hypertension, congestive heart failure, COPD, asthma, etc. And again, because these are care management services, they are not valued at or paid at a rate that assumes that they're being personally performed by a physician or a nurse practitioner. They're actually valued to be provided by clinical staff, professionals who, a nurse or an LPN who cannot independently bill the Medicare program, but they're directed, they're overseen by a qualified healthcare professional. And then again, these are per calendar month. Advanced primary care management services, the third code, I think I said 4 codes, 3 codes. The last of these is for a patient who has 2 or more chronic conditions and who is a qualified Medicare beneficiary, the way that term is defined under the Medicare program. So we have, if you look down at the bottom, the difference between these or among these 3 codes is a patient who has 1 or fewer, so 1 or 0 chronic conditions, who's being managed by generally a primary care specialty. Patients who have 2 or more chronic conditions, and then 2 or more who is a qualified Medicare beneficiary. I want to compare the valuation of these codes, what was proposed versus what was finalized. They ended up being finalized in a way that's very similar to what was proposed in terms of the actual dollar amount. So when the proposed rule came out, you see on the left-hand side some placeholders here. That's because we didn't have codes established if they weren't actually finalized, but they were finalized. And the rate for a patient with 1 or fewer, I guess 1 or 0, chronic conditions went from $10 to $15, but the payment amounts for the other 2 codes remain the same based on what was proposed and what was finalized. Along that same line, I want to go through several services that are brand new for 2025 under the Medicare program that are specific to mental and behavioral health care services. And CMS says one of the things they continue to see, they continue to observe, is a challenge in accessing important mental and behavioral health care services. That's also one of their focuses under telehealth policy in whether and how they finalize certain flexibilities. Mental and behavioral health is a particular focus area where they're trying to discern, do we make these across the board, or should we at least make certain flexibilities available for mental and behavioral health services, not necessarily limited to mental behavioral health specialties, but it is the service themselves that's the focus. So for 2025, several new codes were created for mental behavioral health services called safety planning interventions. I think of it as being very similar to crisis intervention codes that we have available in the medicine section of CPT that are already paid by CMS, but with some slight variation in terms of what this covers. Post-discharge telephone follow-up. Like transitional care management, but with a focus on mental and behavioral health care issues. Digital mental health treatment, they look and they're structured very similar to the way remote physiologic monitoring is set up, or remote therapeutic monitoring. So I'll show you what those codes look like. And then interprofessional consultations with professionals that are authorized to treat mental and behavioral health conditions. So let me start with the first of these new categories of services under the Medicare program, safety planning interventions. This is an add-on code that will be reported or was intended to be reported in addition to an evaluation and management code. But if you look down to the bottom of the screen, I've crossed that out because while it was proposed to be an add-on code, one, I think, positive change that Medicare made in the final rule is allowing the new code for safety planning interventions, to be reported as a standalone service and does not necessarily have to be reported on the same day as an evaluation and management service that has been rendered to a patient. The way these are described, it's an intervention with assisting the patient to identify certain elements of a safety plan when it comes to mental and behavioral health conditions. So helping the patient recognize warning signs of some, impending decompensation or exacerbation of mental behavioral health issues. So warning signs of a potential crisis. What are the coping strategies that will be used as the patient develops the tools and the strategies to identify those warning signs? What are the social contacts that the patient can reach out to when and if that were to occur? Kind of helping them distract them from any suicidal ideation or suicidal thoughts in the event one of those crisis scenarios occurs. Leveraging family members, leveraging social services, significant others to help resolve the crisis, and then contacting mental health professionals during those agencies. So this is the planning process, and CMS is recognizing this planning process involves work, it involves time, and can be done as a standalone service. It's going to be billed in increments of 20 minutes, so 20-minute increments. The work RVU for this service was finalized at 1.09. So we have a conversion factor of 36. I can't remember exactly what the exact number is. So around a little over $36 for the service. Now, unlike some of the other services that are care management that we've been talking about can be done by clinical staff rather than by the billing provider. One change CMS made in the final rule is that this needs to be personally performed by the billing provider. CMS did not, in stating that, CMS doesn't discuss and address whether it can be billed as an incident to service. So one might make assumptions either way, but reading the exact language of the final rule says it needs to be personally performed by the billing professional. Another category of new services for 2025, CMS talks about post-discharge telephone follow-up for a patient. Monthly billing code to describe the specific protocols that are involved in reaching out to the patient by phone in conjunction with a discharge from the emergency department. So unlike some of our transitional care management that contemplates a discharge from an inpatient stay or a stay in the hospital, this discharge is referring to a patient who went to the emergency department and left rather than being admitted for observation or for inpatient services. So we're going to reach out, connect with the patient who went to the ED for an emergency or kind of a mental health, behavioral health crisis scenario. And we'll bundle the calls that were involved in this post-discharge connection with the patient, lasting 10 to 20 minutes. This can be billed regardless of whether the HCPCS code that's finalized for this service was also furnished and billed on the same day as evaluation and management services for the patient, and requires at least one real-time interaction with the patient. CMS clarified if you try to reach out to the patient by phone and are unable to reach the patient, you are not able to bill G0544 for those services. That doesn't qualify as the real-time telephone interaction with the patient. It's important to keep in mind cost sharing applies for these services. None of these new mental behavioral services that are created for 2025 are considered preventive. So the patient will have cost sharing, which also means there needs to be consent from the patient to engage in the service in order to bill for it. I think I said on the previous slide, 1.09 work RVUs was 36. I should clarify, the work RVU component is 36. The total RVU component is going to come closer to the $50 range for the safety planning interventions. Same for G0544, the new code for post-discharge, post-ED visit, mental behavioral telephone contact with a patient, around $56, depending on any geographic adjustments for that code. So the next group of codes is called digital mental health treatment. We've talked in previous sessions about remote patient monitoring, where you give the patient a device and you can bill for the time and the setup and the education, telling the patient how to use this device to monitor certain physiologic parameters like blood pressure, heart rate, temperature, weight, things along those lines. You can also bill every month for the cost of the equipment that the patient is using to measure those physiologic parameters. And there are codes that can be reported on the provider's end when the data comes in and is electronically transmitted to the provider for monitoring those values and managing the patient's care plan based on what those values are. There's also a set of codes called remote therapeutic monitoring, where unlike RPM, which is physiologic parameters, remote therapeutic monitoring was focused on things like respiratory status, focused on musculoskeletal conditions of the patient. But the digital mental health treatment is a very similar concept to those benefits that have been created over the last several years. This is making payment to professionals for digital mental health treatment for the devices given to patients that are integral to other behavioral health care services. So we're giving the patient a device that has been cleared by the FDA. So that's one distinction here from remote patient monitoring and remote therapeutic monitoring. Remote therapeutic and physiologic monitoring do not require a device that is cleared by the FDA specifically for this purpose. Those benefits only require the use of a device that meets the definition of a medical device under the FDA, which is extremely broad. So for digital mental health treatment, the actual product that you're using, the actual device that you give the patient for this mental health and behavioral health monitoring has to be cleared by the FDA before you can build a Medicare program for these services. The ongoing monitoring of the patient for mental behavioral health conditions on a month-to-month basis using this FDA cleared device has to be part of a treatment plan that has been established by the patient's billing professional. So here's a series of codes. And if you look at these, they're structured very similar to remote patient monitoring and remote therapeutic monitoring. We have a one-time code that the setup, the supply of the device, initial education and onboarding with the patient on how to use it, what their care plan is, etc. The second code is the treatment management. So that's the receipt and monitoring the data that comes in from the patient from this device, and then managing the patient's mental behavioral health treatment based on the data that's coming in. These are calendar month codes and involve at least one interactive communication. They don't define that has to be in person. That can be a telephone service with the patient or with a caregiver during the calendar month. And then each additional 20 minutes of time during a calendar month for that treatment management services. Interprofessional consultations are also a new category of benefits. We've got quite a few codes in this category that will recognize and allow payment when a professional needs to consult with maybe a psychiatrist, maybe a psychologist, but someone who treats mental and behavioral health conditions. These codes, they're time-based. So we're going to see just a hierarchy, 5 to 10 minutes, 10 to 20 minutes, probably getting the time frames wrong, but that outline how long you're providing the service, very much like phone call codes do currently. Because these are billed under with respect to an individual patient, and there is cost sharing that's applied, the code is determined on whether there's written verbal consultation, but we will have to get patient consent for the consultation services. So these are the time-based codes, 5 to 10 minutes, 11 to 20, not 10 to 20, 11 to 20, 21 to 30 minutes of time. And that can be a phone call conversation that can be email communications, secure communications back and forth between professionals about a patient's case, 31 minutes or more. And then G0550 and G0551. So these are referring to an assessment with a written report by that consulting professional, as opposed to just a conversation among professionals. And the same for the second one, interprofessional consult provided by the requesting practitioner for diagnosis and treatment of mental illness, about 30 minutes of time. And then the last, one of the last categories I want to go through are policies for RHCs and FQHCs, and specifically when it comes to care management services. So prior to 2024, RHCs and FQHCs were able to deliver care management services and bill for those services separate from their all-inclusive rate or their PPS rate. At that time, regardless of what type of care management service was performed, transitional care management, chronic care management, all the way down to principal illness navigation, the RHCs and the FQHCs used one code, G0511. That one code, they billed, they were paid a single amount regardless of what care management service was delivered. And then for this calendar year, Medicare modified that policy a little bit to vary how that single dollar amount for code G0511 was arrived at. It's a weighted average. So CMS looked at how often transitional care management, chronic care management, principal care management were performed by RHCs and FQHCs, and created a weighted average for that number. Where previously it was just what is the number for transitional care, what is the number for chronic care, and an average of those services. This was a weighted average. But in 2025, CMS is recognizing that it might be beneficial for RHCs and FQHCs to actually report the exact same HCPCS code that other provider types would report for each of those individual care management services, and proposed to do that. Now, RHCs and FQHCs would report the unique code for the specific care management service they're rendered and be paid at the specific fee schedule allowable for that individual code, rather than an overall average or a weighted average that had been used previously. CMS finalized that policy. So this could be a very significant change for RHCs and FQHCs in terms of billing, having to designate the individual HCPCS codes now, where previously it was one code regardless of what you provided. But it does create the potential opportunity to achieve better reimbursement for the exact care management services that you're providing, potentially, that might have had an actual fee schedule allowable that's higher than what the weighted average has been paid for those services. These will continue to be billed and paid separate from your all-inclusive or your PPS rates. Now it's November 20th. That doesn't give you a lot of time if you are an RHC or an FQHC to implement this rule. So CMS says they're going to give you a grace period of 6 months, so through the end of June 2025, to change your coding and billing practice from using G0511, regardless of what care management service you're providing, to using the individual HCPCS codes for each individual care management service in your billing. Added to the list, the new advanced primary care model codes will also be eligible care management services for RHCs and for FQHCs to provide and to bill for, separate from their all-inclusive rate, separate from their PPS rate, beginning January 1. January 1 through June, you could do that by using G0511, or you could just adopt that model and start using the individual HCPCS codes for those services right at the beginning of the year. There's also a few telehealth policies that were adopted specific to RHCs and FQHCs. One of those is to continue the flexibility for RHCs and FQHCs to satisfy the direct supervision requirement for incident to billing by using virtual presence, meaning the FQHC or the RHC provider is available to immediately intervene during an FQHC or RHC service via telehealth, but does not actually have to be in the office suite and immediately available, nor have to be personally present during that session. This is an orange check mark because while it was discussed as possibly making this a permanent flexibility, at this time it was just extended for another year. And I think the reason it may have been just extended versus made permanent is because we have to wait for the act of Congress, we have to wait for federal legislation to say that RHCs and FQHCs can continue to be distant site billers at least through next year, or will permanently be made eligible distant site billers for the telehealth benefit under the Social Security Act. I suspect if they become permanently eligible distant site billers, that this policy likely would become a permanent policy in future years. Bill G2025 on the claim for those telehealth services in the RHC and the FQHC setting. And CMS is also continuing to delay the in-person visit requirement for certain mental behavioral health care services delivered via telehealth format in the absence of a substance use disorder. We'll hopefully we'll visit that depending on what the final policies are for 2026. But absent federal legislation, at some point, both RHCs, FQHCs, and other healthcare professionals providing a mental behavioral healthcare service in the absence of coexisting substance use disorders via telehealth will need to have an in-person visit with the patient within the preceding 6 months before that visit can be done via telehealth, but that has not come back into effect as a requirement yet for RHCs or FQHCs or any other healthcare provider. Other good news for RHCs and FQHCs involve some preventive services policies so they can bill and be paid separate from their all-inclusive rate, separate from their PPS rates for the administration of Medicare covered vaccines. So that's the pneumonia vaccine, influenza, Hep B, and the COVID-19 vaccine. This kind of walks through what the payment will be for those different vaccines, but the good thing to know is that you can bill and be paid for the administration separately. The last couple of things I wanted to touch on as we kind of near the top of the hour, those of you that are in the state of Missouri, wanted you to be aware of a Missouri Medicaid, Missouri Health Net policy on place of service reporting that's going to be taking effect here in about a month, December of 2024. This is on place of service reporting for telehealth services. Place of service 10 was a new telehealth place of service code that was created specifically to identify when telehealth was being rendered to a patient to a patient who is at home versus in other originating sites like the clinic setting or the hospital setting. Missouri Health Net had not been utilizing that code or requiring that code, but will be using that code effective December 22nd, 2024, and will require either a 10 or a 2, depending on whether or not the patient is in the patient's home when the telehealth site telehealth service was rendered. We'll have a link on the slides when we send them out if you want to go out and view that actual policy. And lastly, just a few weeks ago, might have even been in the last week, the Drug Enforcement Administration, who also has their kind of hands in the telehealth policy with respect to prescriptions of controlled substances that may be made during a telehealth visit. We not only have to worry about CMS policy for the visit itself, but whether providers are allowed to make certain prescriptions for controlled substances during a telehealth visit. And that's the DEA, not CMS. Since the public health emergency ended, where or when the DEA had a flexibility during the PHE to waive certain requirements that there must be an in-person face-to-face visit with a patient before certain controlled substances were prescribed via telehealth, called the Ryan-Haidt Act. That was waived during the PHE, and instead of putting that face-to-face in-person visit requirement back into effect, there have been extensions ever since the public health emergency ended. Similar to the act of Congress that we're expecting here at kind of the 11th hour at the end of the year, the DEA has tended to make their extensions at the 11th hour. The extension that would have ended December 31st, 2024, saying we would have to revert back to seeing a patient in person before making certain prescriptions for controlled substances, has now been extended again, not been made permanent, but will be extended through December 31st of 2025. So I imagine when we have this same session next year talking about 2026 policy, we might be discussing whether the DEA has finalized their policy yet, or if they're extending that policy for an additional period of time. So with that, I think we've got a couple of minutes. I don't know if we have some questions in the chat, Molly and Haley, that we can get to. And of course, anything that we don't get to as part of this session, we'll do our best to respond, take those questions and respond out to the group as we send materials afterwards.
Yes, yeah, as a reminder, we will be sending out a follow-up email with the recording and the PowerPoint slides, as well as answers to any questions that we didn't get to. But we do have a couple of minutes, so I will read one that came in earlier. CMS was vague about its process for performing the comprehensive assessment of all telehealth codes. Is the February 2025 deadline the process by which the agency will perform its final review?
That's a great question. They were really vague about wanting to kind of take the list of those services that are provisionally covered as telehealth and make them permanent telehealth services. Those in the provisional bucket, they're only there as a result of the PHE, and CMS didn't want to take them off yet, but wasn't quite ready to make a decision on safety and efficacy to make them permanently eligible telehealth services. I anticipate that's going to be part of the 2026 proposed rule that may come out in July, or we continue this concept of provisionally covered telehealth services yet another year while CMS evaluates what they want to do for permanent policy. But what I would encourage, not knowing if they are looking at that for 2026 rulemaking or contemplate making that at some further point in the future, February 10th, 2025 is a great opportunity for you to give input in the event CMS is doing that analysis for the next year to make sure you're providing any data, any provider stakeholder feedback on access and efficacy if you're wanting to encourage CMS to make certain portions or all of those permanently eligible telehealth services in 2026 and beyond.
Thank you. Can you clarify if extension of the waiver for the in-person visit requirement for behavioral health telehealth visits through 2025 applies to FQHCs, rural health centers only, or any site providing telebehavioral health?
That's a great question. I think I said during the session it was both, but let me triple check that, Molly, and we'll send that out with the final materials. And I think so this is referring to a telehealth service for an individual who has mental or behavioral health conditions, but does not have substance use disorder. A patient who has co-occurring substance use disorder or a visit specific to substance use disorder can be rendered via telehealth without requiring an in-person visit. And then this new sort of expanded access, regardless of whether the patient is at home in a rural geographic area or not. Permanently, we will be able to deliver these mental behavioral health services via telehealth, regardless of this impending act of Congress on originating sites, rural geographic areas, etc. This will be a permanent telehealth benefit. However, if it does not co-occur with substance use disorder, for whatever reason, Congress added a requirement that there would be an in-person visit in 6 months preceding that visit. And that would apply under the statute, regardless of whether there's FQHC or RHC. I'm specifically remembering seeing that extension under the RHC and FQHC section. But to the individual that put that question in the chat, that's a great question. I will go back and triple check that that was also extended for all other provider types as well.
I think that concludes our webinar for today. We have taken down all the questions in the chat. And please note that if you would like a certificate, email us at htrc@kumc.edu. We also put it in the chat as well. And then we will answer any remaining questions in our follow-up email, send the link, and our PowerPoint presentation. Thank you, Richelle.